Good evening, everybody. And yeah, today I am more happy than what I am usually be. If you find me grumpy, I'm not a grumpy person usually. So, dear colleagues, so I would be taking around one presentation of around 10 to 15 minutes, telling you people or taking you people through the journey of MDM, which happened over last 1 year. And why it is necessary is because whenever we do something, we should introspect and see what we did right, what we did wrong, and we should take suggestion from more wise people. And we have got many wise people today available with us, like Talwar sir, Athol Wells, Bhavin Jankaria sir, Vimal Raj sir, Rajan sir and Murli sir will be joining us, Prahlad Prabhu Desai sir, and Ravindran Nair sir. Most of the people whom I have sent personal link has supported this particular MDM in direct or indirect way. And because of that, we wanted them to be here when we are doing this. So without further overdue, I would like to start my audit presentation first because that is what we are going to discuss about, that how we can improve. Is my slides visible?
Yes, yes.
Yeah. So this all the things started. Why I have put build summit slide is you can see this picture, and here is the Talwar sir with his conversation. We had a conversation in one conference, and I told him that I wanted to do something on ILD, and he told that he will be supporting me. And along with that, Rajan sir came on board, and that is how all this started. So Build Summit 24 was South India's first dedicated ILD conference. In that conference, when we discussed, we found out that there was a need for some platform to simplify challenges of ILD management. And that is when we conceptualized the ILD Pan India multidisciplinary meeting. It started with all three of us along with Bhavin sir. Bhavin sir was the main person during that particular time because we wanted a very good radiologist, and he agreed in his busy schedule. That was like a miracle to me, and that was all thanks to Rajan sir, who would have convinced him, I believe so. And this is like anybody can comment in between, so no problem. So because of Bhavin sir and Talwar sir and Rajan sir, we four people started initially. And then what happened is initial few days we only were discussing. I had a good support from Tinku and Shobha madam in during earlier time. Dr. Richa and Arjun were the one who supported me for presentation of cases, because when you start something new, you will have inhibition from the world, like whether it will be good or whether it will be bad, and people will have their own reservation for joining the program. So initial few days we were the one, or they were the one who supported us. So this were the three people or four people we started, and after that Bhavin sir was like finding it difficult that one person doing every time will not work. And I met Dr. Vimal Raj in Ahmedabad for one conference, and I just told him that I'm doing something like this, will you please agree for doing this with us alternate week? And then sir kindly agreed, and he told, please forward it. And that is how this next radiologist who joined was Vimal Raj sir. And then later on, Aparna also joined. So all three of them, very big thank you to all of you, because CT radiologist is, as Rajan sir says, is the main part of our presentation. Ritu madam was the one who joined. Before that, there was
Hey,
one.
Asmita, sorry to interrupt you. Can you
Yeah.
repeat that sentence again, that the radiologist is the main and the most important part of
Oh
the
my God, I
MDM?
can
Yes.
repeat it 10 times if you want.
Sorry, go ahead. Yeah.
Yeah. So CT radiologist is
I
the
hope
main
Aparna and
part.
Vimal are listening to this, so all of us should take a bow.
Yeah. CT
Yes.
radiologists
Thank you.
are the main part of our MDM. And that is why the only compulsory thing for our meeting is DICOM images. We have not asked for histopathology. But
Yes.
having said that, I do not want to make Ritu madam unhappy, because she has made so many different diagnoses, and that is what this presentation about. And we had always had Mithun, but today Mithun has gone for some meeting, some wedding, so we do not have Mithun today. But other people, this all three rheumatologists are from my hospital, and Jyoti madam and Sandeep were also always peeping in when Mithun is not available. Thank you so much to all. And then later on we had got Murli sir and Prahlad Prabhu Desai sir, and we had once or twice Sajal Dhuria also. Now, alongside national faculty, we have internationally acclaimed faculty. That also thanks to, I think, Ethel Wells and Katrina both were brought by Rajan sir, and they were so kind. I was so happy that somebody is willing to spend 1 hour, and all the audience who are listening, there is no honorarium, there is nothing which is being paid to anybody who is coming for this meeting. And you can imagine that all those people who are coming for this meeting, all the experts, they are sparing their valuable time just for teaching an academic purpose. So I believe that we all are very grateful to all the experts who are sparing their so much valuable time for us. And because Vesalius was the best person for sarcoidosis, that is what Athol Wells has said. So he also joined one or twice. So those people who don't understand Hindi or Urdu, but I can't describe it in this particular all the experts meeting in any other way other than मैं अकेला ही चला था जानिबे मंजिल मगर लोग साथ आते गए और कारवा बनता गया. And that is what we have done in this meeting. Having said that, these are all the faculties which have contributed for our momentum keep going. So Dr. A. Suresh, Dr. Abhishek Tandon, Dr. Ajay Ravi, Dr. Alpa Dalal, Dr. Amila Ratnapala. Talwar sir was the one person who was initially giving all ILD 1 or 2 cases when I started, and when I was having so much difficulty, he was the one who supported me. Harjit Singh Dumra presented twice. Madhu sir from Calicut presented twice. Mehul Sai Mumbai from Mumbai has 1 case. Mujib Rahman had given me 1 case. Murli Mohan sir is always our expert, as well as any time when I am having like, sir, any case you have got, he will be always willing to provide difficult cases. Arjun has supported us. Pooja Bajaj, Pradeep Bajaj, Prakhar Sharma is now latest entry, but he's so regular that I am having very promising idea about him that like me and Rajan sir, he also will be a regular presenter. That's what I believe. The way he's presenting cases in our MDM. Other people which I have to remember is Richa Gupta madam, who is always supporting for me from my very early days, even now also. Shobha madam and Tinku, as I told in early days, they were the one and they were always supporting me in whatever I do. Rushali, Yash Rana from Rajkot is the one young pulmonologist, and he presented very interesting case of 10-year-old girl and who was only familial ILD, which we came across, which was having genetic profile done for her. And today, actually, Katrina wanted to present some case, but unfortunately, we could not take it because of unavailability of CT images. So this is like if I have forgotten somebody's name, please believe me, it is not intentional. I tried to put together whomsoever I remember. Sajita presented a very nice case of cystic ILD. Yuvraj was the one who supported me in initial days. Ram Nathan sir, Sneha Panikar is, I think, Arjun's colleague. Vidya Nair is Arjun's colleague. So all of you, big thanks to all of you for making this such a successful program. And it was difficult to carry on 1 year. Believe me, there were many times which we would have given up just because we were working as a team. We just carried on. So now coming to the data. So we had around 90 cases total. Out of this, these are the baseline demographics, and I won't go and spend my time talking about those things. So what I have done is I would like to have input from Athol Wells and Bhavin sir and Talwar sir and sir, Rajan sir. So this is what I understood, that what we do in MDM is we will have a pre-diagnosis and we will have a post-diagnosis, and most of the studies have tried to find out concordance between the pre-diagnosis and post-diagnosis as well as the consensus diagnosis. So what I found out that if your pre-diagnosis was HP, matlab radiology diagnosis was HP, there was highest concordance in the radiology compared to other diseases. Sarcoidosis, we had around 53% concordance. In UIP, it was around 73%. In NSIP, it was 60%. In OP NSIP kind of pattern, it was 50%. And others were mainly infection. It was not a ILD diagnosis as such. Those cases were fall into, I have put into others. Mostly those who didn't fall into any of the above. So you can see that the maximum radiological concordance was among HP and IPF patients. And surprisingly, like I don't know why Bhavin sir, but and Vimalraj sir and Aparna said, but it was only 54% for sarcoidosis. Now coming to histopathological diagnosis, not all the patient histopathology was done, but HP concordance was only 43%. Sarcoidosis had 60% concordance pre and post, and one patient, three patient out of five patient where UIP was coming in a picture, and OP was 50%, 50% each. So this is a overall diagnosis concordance, and that also is very much similar. That if overall diagnosis pre was HP, only concordance was 40%, while if it was a sarcoidosis, even the post meeting diagnosis remains sarcoid in 67% of cases. In IPF, sorry, it is not IPF, it is IPF, idiopathic pulmonary fibrosis, almost 78% pre and post diagnosis matched. In NSIP CTD also, it was maximum matching, that if a pre-diagnosis was CTD NSIP, even post meeting also it remained like that. There were OP organizing pneumonia was around 60% and others were always matching. So we did a Kendall's concordance coefficient analysis for that. And as you can find out, this is what the results were. And most of the times we match that IPF was having 78% concordance in uh, post discussion, as well as CTD was highest. CTD and IPF were highest, followed by OPNSIP and sarcoidosis. However, HP didn't match. I don't know why, but hypersensitivity pneumonitis has got only 40% pre and post matching. So this is all the results which I could make out from 90 patients which we did. So HP was 77% concordance among radiologists pre and post, 43% among pathologists, and 40% in clinicians. Sarcoidosis had highest concordance among clinicians with 67% pre and post clinicians agreed, followed by pathologists 60%. However, radiologists were agreeable only in 54% cases. So I'm talking about the radiologists who diagnosed previously, then after discussion. Now IPF had 78% agreement in clinicians, followed by radiologists in 73%. CTD NSIP was one of the diagnoses which was almost acceptable by pre and post most of the times. However, radiologists, there was some 60%, so 40% disagreement among radiologists. Organizing pneumonia, 60% clinicians and 50% each among radiologists and pathologists. That is a summary of the results, and I can show the results again if you people want, but my take home message from this particular 1 year is, as we celebrate the first anniversary of this particular initiative, we are not just looking back, but we are paving the way forward. Our mission is to reach more clinicians, expand our impact, and continue making difference where it matters most. So the road ahead is very promising, and we all can together continue shaping the future of ILD. So let us keep walking the road less traveled together. And as I said, I started alone towards the destination, but people kept joining, and a Karwa was formed. With that, I would end my presentation, and we can have inputs from all the people who took their time to join today. Yeah.
Amazing, amazing. It's amazing, that and the kind of work which you have done and collated the data so well. Maybe a little disheartening from the aspect because I was always under the impression that HP will get maximum concordance,
Mm.
OP will also get equally very high concordance.
Mm.
These two diseases came the lowest in your list. So
Yeah, I was also like HP was really disheartening for me also,
very,
because
very
we
disheartening
we
from
make
your
we make HP diagnosis right and left, isn't it? Anything which is not UIP is HP for us mostly.
It's
Like,
a take home that we overdiagnose HP
yeah.
in India, and we need more histopathology as well as radiology and an MDT teams to look into it. It's a different disease together, but great work. I think I'm sure you are going to publish it.
we
So
will
I'm
try. We'll
worried.
try.
So Dr. Asmita, I'm worried. Is my job safe or is it completely over now? What is it?
No, ma'am. Actually, I was telling my research assistant that we should put how many total biopsy was taken, because if we see hardly 30 biopsy were among out of this 90, not even one third cases were having biopsy, and few cases, ma'am, when we have missed something, you people make it proper. So I believe Athol, well, what I have understood is pathologist concordance is the list, radiologist is maximum. To the in published data, I believe two radiologists agreeable is far more common than two clinicians, than two pathologists. That's what I believe. But I think sir has raised hand, so let us hear from sir.
A couple of comments. You thank the international participants, but I think they should thank you actually, because this has been a fabulous discussion forum.
Thank you.
With a good deal of banter and a great deal of forensic discussion. I particularly pay tribute to Bhavin, not so much for his imaging expertise, but for the rich fantasy life he has that he brings to the meeting, as witness his comments about the importance of radiologists. Yes, I think that this should be worked to publication. What I would say is just be careful about the sub-disease analyses. You didn't have much OP, and I suspect people bring difficult OP to the meeting. So I'm not sure that I'd be worried about the discordance on OP. I do think you might summarize everything in one analysis as well. You've broken down all of the individual disorders, but just to get a whole population change in diagnosis. And I would imagine when you look at imaging having more concordance in some disorders, clinicians more concordance in others, you might very well find out across the whole population that the concordance ends up being fairly equivalent. So that's really all I wanted to say, and just to congratulate you on a magnificent multidisciplinary forum. It's no penalty in time for me because it is so enjoyable that I only regret when I can't come.
No, we also regret actually, even though Rajan sir never wants to admit it in front of you. Rajan sir, your comments, because we both like started initially, and you brought Athol Wells and Bhavin sir on board. So what is your, like, what should be way forward? What should we do bit differently, sir?
Nothing to add. I think we're doing it fine. Asmita, you've been doing a fantastic job. As I always told you in the beginning, and I maintain, it needs one person to run it, and you have run it brilliantly. And it takes a lot of effort, not just from the clinicians but a lot of effort from the radiologists, as Bhavin said, getting those slides in, collating the data, and ensure we stick to time and not go too late into the evening, which many have requested us for. And I think you've stuck to that time. And I think, and that's what's helped. So, and I think we should continue to stick to that in the best way possible.
Yes.
Thank you for involving me in it. Thank you.
Yes, Bhavin sir.
I'm going to add one thing quickly. I think what's been outstanding is the way you've adapted the meeting. You've worked out what needed to change, and you've changed it relatively quickly. Some of us had bright ideas to start with as to what the right format was, and you very politely dismissed some of these questions and actually gave us the real answers with the way you adapted the meeting. Congratulations, Asmita.
Yeah, thank you.
I think,
yes, sir.
no, I think the wonderful thing is also there are 2, 3 things in the Indian setting that are always commendable. One is consistency. Sometimes the only important thing is to show up. And if you just keep doing the meeting, irrespective of who's there, not there, eventually it takes a life of its own, which you've been so good at. You're persistent, you're making sure the meeting happens, and then automatically things follow. And the second thing was the adaptability, as Athol said. I remember the first couple of meetings, we were taking half an hour per case and then rushing through the next ones. And then we managed to cut down to about 10 minutes a case. We've done a few cases in 6 minutes. And, eventually, so we used to overrun to 1 hour, 15 minutes, and sometimes 1.5 hours. I think overall, we've managed to stick to time very well. And I think that's really helpful. And then getting, I think Vimal and Aparna on board has helped a lot, because in the end, you need different radiologists to be involved.
Yes.
at multiple times. So great work. Thank you.
Yeah, Katrina. Katrina was a regular visitor in the earlier meetings and then she became busy. But whenever she is there, she brings a very fresh this thing touch for our meetings because with her smile and all.
Yes, I would like to thank you for giving me the opportunity to be
Our
with
pleasure.
you. Yes, and I think that I think I enjoyed a lot. I learned a lot. I promise that I will also present cases
Yes.
from my work here in Crete. I think it was always a debate when Athol was also there, and
Yeah.
I enjoyed a lot the discussions. So I will try to be present. It is a Friday, it's a difficult day. Sometimes we travel, but
Yeah.
I think we have to keep it. And my best wishes for next year, for the
Sure.
second birthday, with
Yeah.
more cases, more discussions, and
No,
more
no.
disagreements.
Definitely,
Thank you
definitely.
so much for giving me this opportunity. And the Vasong Congress in India was an opportunity for me
For seeing you personally,
yes,
yeah,
yes, to see you
definitely,
personally.
definitely.
Yes,
Yeah,
yes,
definitely, definitely.
yes. So it was fabulous, and thank you all of you.
Vimal Raj sir, you don't talk much, but you have to say something. Hello. Yeah.
I do have to say thank you very much for having me in this. I
Well,
really
thank you, sir.
enjoyed it. It's as everyone says, they're quite challenging cases,
Yeah.
and it's always a great learning experience. And I just enjoy the banter, but I do know I'm spared from Athol's banter because he has a predilection towards
Yeah, yeah,
Bhavin, so
yeah.
I do escape
He
from that
yeah.
banter. But no,
They
thank you
work.
very much.
They work
Thoroughly
good.
enjoyed it, and I'm sure we will have more and more birthdays to celebrate
Yeah.
from here.
Thank you.
I'm
Thank you.
very happy to adapt my targets in future.
Yeah, yeah, yeah. So,
And,
so,
and
so yes,
Smita,
and yes, sir.
yeah. Sorry, I would like to there is some problem in the video. Okay. But I'm there since beginning.
It's okay. We can. I think because you are joining from two device, I will disable one.
Yeah. All right. Okay. So I think we long back, Sujit, myself, and Bhavin plan to.
I think you join only from one device that it will work.
One device only. Okay. Yeah.
Yeah.
Yeah,
Now
now
it's
you're
fine.
on one device. Yeah.
Yeah, it's fine. Please go ahead.
Sorry. So we tried in person actually, Sujit, myself, and Bhavin long back, and we could try to do it for 1 year. But I never realized, Asmita, कि web-based meetings can be so successful. So it's a really the credit goes to actually speaking you and Bhavin and Sujit to start it. It's so the radiology is so easy, even pathology also you can read so very
So
well.
easy, so
Okay,
easy.
so easily. So I think this is something which is going to be a future of MDTs,
Hmm.
where we can have more feasibility because of this technology. Otherwise, meeting together is so difficult. Sujit knows that we have to run from here and there, collecting cases. So
No,
from
but you can see, sir, that Bhavin sir is sitting in Mumbai, Ritu madam is
yeah,
sitting in BP, Talwar sir is in Noida, I am in Kochi. Like we all are,
this is because of
yeah,
COVID, I feel.
yeah. It has to be
Because
given.
of
The
COVID.
credit has to be
Credit
given to
has to be
COVID.
given to COVID. And
COVID
we
made
will
it
try. We
possible.
will try to send more patients. Actually, there are plenty of patients. There is some inertia, but will Bhavi, me, and Sujit also will try to send more patients from Mumbai also.
Yeah, yesterday RMPL Ramanathan sir had a brief chat with me and he was like, Smita, this particular MDM is not sufficient to cover the entire India and we have to do more. Manika sir, in this also myself, Rajan sir, Prakhar, there are few selected people who just keep on repeatedly presenting because people are not presenting and you are telling me that this is not enough. I am happy to hear that because we have got very selected people who present. So if anybody, Murli sir, yes, how can I forget Murli sir? Because Murli Mohan sir and Prahlad Prabhu Desai sir is the one who came later on, but now they have become regular member of our particular MDM. It won't be complete without your comments, sir. You're muted. I can't see you, so. Murli sir. Okay, if we have lost him, Rajan sir, you want to present your case or you're driving or something?
Dr. Asmita, just.
I'll-
Hello,
Yes.
Dr. Asmita.
Yeah, Ravindran sir, please.
Yes. I am Dr. Ravindran Nair from Trivandrum. So, first of all, a hearty congratulations and big thanks to Dr. Asmita for your phenomenal accomplishment over a span of just 1 year. Your perseverance, dedication, and commitment to the problem solving in ILD is something which has to be admired. And with special thanks to Dr. Bhavin, Dr. Rajan, Dr. Deepak Talwar, and all. I think it is a fantastic show. I think we have to keep the momentum going. So once again, congratulations.
Okay. Thank you. Thank you, sir. Thank you. He was the one who initial days used to send me always encouraging messages to move forward. Yes, Murli sir.
During one conference, I was just talking to Dr. Sujit Rajan regarding the necessity of having an MDM in place.
Yeah. So that's how the idea came. That's so true. Yeah, that's so true. Yeah. Actually, it all started with build. If I have to say something, it is like all we met first time, Rajan sir and myself and Talwar sir and all. We started build, and that's how it came. But in that also, Murli Mohan sir, few people were always there, isn't it?
Yes.
Yeah.
I think from your end, things will go on moving forward. No problem.
We will try our best to keep the standards
right.
as much high as it is right now. Murli sir, you want to say few?
No, just congratulations. It's been an amazing effort. I've been catching little bits of it because I've been seeing patients in between. But honestly, this would not succeed without your continuing strong effort. And of course, it's, Sujit coming on every week.
Yeah, Bhavin sir, everybody is so busy. Talwar sir, everybody is so busy.
So congratulations and hope to see this go on for a very, very, very long time.
Hopefully. Which case we want to start with, sir? Your case?
I think go ahead, Asmita. I'll do the second or the third or
Yeah. I will present two cases and I'll present two cases. So this is Mr. P. Bhavin sir. So this is very, as I told, this must be a very simple case. But why I'm presenting is there is a reason. So this was a 79 years. He is still there. So 79 years old man from Kottayam, when he was exposed to some material when he was working as an electricity board engineer with multiple comorbidities. 2015, he was diagnosed as adenocarcinoma. Since he was not fit for surgery, he received radiation on that particular part and post NSCT chemotherapy and consolidation RT in February 2016. Now, all these things happen. I think I was in a picture only for biopsy or something, and I don't know anything in between. And suddenly he came to me in 2024 December. When he came to us, he had presented with complaint of breathing difficulty, which is MMRC grade 2 to grade 3, with no other constitutional symptoms. And he was 94 room air saturation with bilateral basal coarse crepitation. So when he was first admitted with me, I felt it was just emphysema or bronchiectasis, and I actually did a bronchoscopy. What we found was multiple secretions, purulent secretions. That is what we found. And why I came in a picture was follow-up PET CT was taken, which was showing lymph node, and my medical oncology colleague Dr. Pavitran sir felt that the lymph node which is coming a new needs screening. So I did EBUS, and the lymph node was huge. But as we can see, even before the diagnosis came, I knew that this must be a reactive lymph node because the kind of secretions which we were seeing was looking like infective. And then I just signed him off and sent him home. He was having a bad COPD, so started him on BiPAP. And after 1 month, he came for review also, and he was perfectly fine. I was thinking that, okay, our worries are done. Now, that was somewhere in 11/24. Both the CT scans can be seen simultaneously. So I will just put the thing properly. So afterwards, what happened is that last week he came back, and this time he came with a very bad exacerbation, and he was still hypoxic in spite of our medicines. And we repeated a CT scan, and this time I was just wondering that is it only emphysema bronchiectasis or are we dealing with some CPFE kind of thing? So that is why the case is being discussed. There are no other questions as such.
May this
And the second interesting part was like we usually see IPF and malignancy. This was a malignancy and IPF.
So, Asmita, do you know what malignancy he had?
Adenocarcinoma.
Of what?
Lung. Yeah, surprisingly, there was one nodule, sir.
Okay, so if we look at this, you can see the screen, right?
Yes, sir.
Okay, so we have a 1st December 2015 scan. And so this must be the nodule, that we're looking at, which is in the anterior segment of the right upper lobe. Is there an echo?
Yeah, I know. No, not your echo. Manish, can you please mute other than Bhavin, sir?
2 year and 1 year, 4 year and 1 year, 1 year, 2 year, or 1 year, 4 years. So first 2 and 1 year.
Dr. Vishali, can you mute, please?
4 and
I think
1 year.
it's Subbu Iyer and Vrishali, one of the two.
1 and 2 year. No, 1 year and 4 year. So as correctly mentioned, this 4 year.
And Vrishali,
This was shown by.
Yeah, now it's gone.
Perfect. So let's start with the first CT, which is 1st December 15, right? And I guess then the nodule that they were looking at was this one in the anterior segment of the right upper lobe. And there are some areas of ground glass patchily in the upper lobes, some subtle reticular opacities in the lung bases, and that's about it. Since he was given radiation, we've got a scan 6 months later, which shows post-RT changes in the right upper lobe. So this explains, the entire appearance here. But we've already started. We don't have HRCT images, but you can see some subtle reticular opacities and cysts here that could just be paraseptal emphysema. And again, we can see a subtle cyst here, some reticular opacities. This is 16. Then we have, so that was May 16. Then we have November 16, where the RT changes have organized better. But we also start seeing some increase in the reticular opacities just within a span of about 6 months in the upper lobes, some other ground glass in the lower lobes, but that could be some superadded inflammation. And if he was still smoking, then it would just be smoking related changes. Then we jump straight 7 years from 16 to 23, at which time he's developed a full-blown ILD. So you have the post-RT changes in the right apex. And then we have honeycombing, reticular opacities. And as we come inferiorly, we kind of see there's a lot of blurring, but there is honeycombing and there are reticular opacities. There is, as far as the mediastinal windows are concerned, there is a subcarinal lymph node. Short axis would be about 17, 18 millimeters, but I think that's pretty much it. And then we find about a year and 2 months later, there is significant progression of the honeycombing, the reticular opacities. This looks like a UIP pattern now in the lower lobes. I'm not seeing too much emphysema, so we just call this a UIP pattern. But let me run through. I'll just remove the soft tissue windows here. Just look at this. So you have 2015 and then 16. Actually, we can remove 116 as well. And now just look at this, right? 15, 16, 23, and 24. And the progression of disease, you hardly had anything in 15. Then you got a little bit of disease in 16. And even between 23 and 24, there is so much progression. So it was slowly, and then, suddenly. So that's where he suddenly become a very fast progressive in the last year or so.
Yeah.
Which is which is the pattern that he now has. So,
So in
pro-
23, na sir, 23, I would I would like to accept my mistake that on this CT scan, I didn't think that I am dealing with fibrosis, even though there was some, but the kind
okay.
of secretions which he was having and the lymph node he was having, my diagnosis was so much of thick secretion. Yeah, as you can see in the upper lobe, na sir, it was like all filled with secretion. So I could not diagnose that whether it was a bronchiectasis or it was honeycombing and all. But when he came with exacerbation somewhere in December 24 or November, we could make out that this is not only that, and that is when I started thinking of CPFE. But you feel there is no paraseptal emphysema?
Nothing significant enough to use that phenotype description. But it's really now, if you have to classify it, forget the etiology. It's just a progressive and a reasonably fast progressive fibrotic
Fibrosis.
ILD.
Yeah.
That's kind of where we are right now.
So yeah, so I'll just share my screen. So questions were very basic, I believe, that is it CPFE that sir has answered, and do we need to treat antifibrotics? And with that, I will stop. So anything, like we have got so many people, so please anyone can start. Talwar sir, if he is there, please tell me, or um, Murli Mohan sir. Do we need to give him antifibrotic? It is very fast progressive. He is already a non-case of CA, and but his quality of life was very good till last 2 years, sir. I don't know. Suddenly he started worsening, and now he is on oxygen and NIV at home. But he's doing well. I was able to discharge him. So should we give him something, nintedanib or anything, sir?
I think, the picture is one of a UIP pattern. So I would probably go ahead and give him an antifibrotic.
Yeah.
What is his quality of life now?
Presently, before exacerbation, he came to see me in OPD and he was perfectly fine. And I was also surprised to see him in ICU when he came last time. And that is when we decided we should repeat a CT scan because nothing was matching. So his quality of life until last exacerbation was quite good. He was mobile. He was off oxygen. He was never on oxygen. Actually, this time I started him on oxygen and BiPAP both.
So, as Bhavin said, he's progressed very rapidly over the last few months. I would certainly try an antifibrotic. My other question, and I'm hoping somebody here will answer it. Should we call this IPF? Because it is associated with a malignancy. We do know that that's a bidirectional connection.
Yeah, that was another reason I wanted to discuss.
IPF is independent risk factor for lung cancer.
No. This lung cancer was before the diagnosis because we saw the CT scan. It was not showing fibrosis at the time of diagnosis of lung cancer. This is like,
data.
Yeah.
I think he had subtle fibrosis that was
Even that
never
time also.
picked up because nobody did any chart. But he's a BD smoker. He's what, 40 to 100 pack years or something like that. So clearly that was anyway there, right? So to begin with. But, Athol did an editorial recently for a radiology article, where he said that we should only look at patterns and stop splitting hair about the exact diagnosis. And this fits into a Hemingway pattern, gradually, then suddenly. And we should have a pattern like that is described. This is exactly what happens. You keep seeing this, they're just slow, and then suddenly the whole thing just,
Yeah. That's so true. That's so true. You can't time it. Yes, sir.
I also would call this IPF unequivocally and manage as for IPF with antifibrotic. Sometimes the art of being wise is the art of knowing what to overlook. And in this case, we probably had an ILA back in 2000 and wherever. The interesting feature is the distribution that the disease developed most prominently in the left upper lobe. I don't know if the radiation initially was just in the right upper lobe, or whether the radiation might at some level have had some sort of synergy, but that's a wild guess. I think the point is, when you see rapidly worsening honeycombing like this, you accept atypical features because you don't understand the cofactors that are driving rapid progression. You accept them and you call this IPF, and I'd make an IPF diagnosis of more than 90% likely. And it's very difficult not to manage that with antifibrotic therapy. In our country, we'd need the lung function, but I'm not suggesting the lung function will change the diagnosis.
Yeah. I don't have also because the last time he came in, he was in ICU. Yeah. Anyone? Rajan sir, Katrina, Prabhu sir. If not, then we'll move.
First of all, congratulations for your effort on this continuing this
Thank
ILD
you.
and
Thank you.
outstanding performance and coordinating this MDT. And before this, I'd like to suggest one thing actually about this discordance between the biopsy and the radiology. I'm just wondering whether we could help with pre-biopsy, before the biopsy, whether we should decide the site with after discussion with the radiologist. I mean, maybe pre-biopsy MDT, and then decide, because the biopsy results will depend on the site of the biopsy, not like the radiology. So what we used to actually, we discuss with the radiologist, and we have pre-biopsy MDT where we decide on the site of the biopsy. That might be kind of be helpful to reduce the discordance between the biopsy and the radiology. That is one of the suggestions. And about this case, I'm just wondering actually that why he's getting these frequent exacerbations. If there's any other new risk factor he might have developed, or I mean, can we, for example, like if there any autoimmunity that he might have developed, that is coming to my mind actually. Whether there's a new risk factor is causing these frequent exacerbations. Thank you.
Okay.
Just to support that last comment, both to choose the biopsy site, but as well as that, we view multidisciplinary discussion as establishing the diagnosis. When you go to biopsy, you need to know what diagnoses are possible, because the nature of possible diagnoses drives biopsy decisions. So it's supremely logical, I believe, to discuss these cases before biopsy, in order to be sure that a biopsy is actually the right decision.
Sure. Anything, Rajan sir, or I'll move on to another case. So this is Mrs. NJ. That is really a challenging case, and that is why we wanted to discuss it today.
You're muted, Asmita. You're muted.
Sorry. Okay. So, sorry for that. So she's a 33 years old lady who is from Ireland, basically from Kerala, but she relocated in Ireland somewhere in 2018. After going there, within 6 months, her problem started. That is what she's saying. She's hypothyroid. However, she says that her antibodies were negative. And after she reached there somewhere in June 2018, January onwards, her problem started with dry cough and breathing difficulty. And she was diagnosed as interstitial lung disease since September 2019 when she visited another hospital in India. So other complaints were recurrent pharyngitis, reactive airway disease, and she developed COVID twice. She's telling that when she developed COVID, it was post-vaccine. And after she received COVID vaccine, she developed all the symptoms of COVID. And since that time, that was in 2021, she has to be put on long-term oxygen therapy. And since that particular month onwards, she is on oxygen as and when required. Of oxygen, her saturation is 92. But if you look, she is having grade 3 clubbing. She is cyanosed. If we don't give her oxygen, she cannot sustain for a long time. She can't even finish sentence without oxygen. That is her severity of illness. Family history of asthma. She told she had, before she went to Ireland, in her house, there were 2 or 3 lovebirds, but that was somewhere 20 years before, and I do not find any correlation in that particular history and her present illness. But since we asked and she said, we are just saying this right now also.
Asmita, can I just interrupt here?
Yes,
I think if she's off oxygen, if I recollect, when I met her online once, her saturation's about 92, 93 or
If
not?
she's not doing anything, she's not talking and she's not coughing.
Excuse me. Yeah.
So what
I
happens?
just
What is her
wanted to.
main? Yeah. So she says that her saturation is 92 if she's sitting quietly. But now presently, why she decided to come to India is she is developing frequent bouts of cough, which makes her so breathless that that feeling is so scary. Yeah, and that is why she came. And every time when the bouts of cough comes, she will vomit, and it doesn't go well easily, and it takes even hours to come to the baseline. So she came here for second opinion of Rajan sir, and because she's from Kerala, she came and saw me because she wanted a CT scan repeat and few investigation we had to do before she goes for transplant. She is very much determined to undergo transplant. We have to understand she's 33 years old, and she is very much motivated for undergoing transplant. That is the background is very important. That's why I'm saying. And uh, other than that, she has recurrent cough, which I already told, dyspnea on exertion, no CTD, so CTD stigmata, except the last time when she came to Kerala, somewhere in October 2024, she had evaluated for dry eye, and she's telling that her Schirmer's test was positive. When I examined, she had grade 3 clubbing, bilateral crepitation, room. She was already breathing oxygen. That time her saturation was 97%. And outside reports, all the investigations were negative from a reliable sources. But still, I did a few investigations again over here. Her ESR is 18. ANA screening is negative. ANA profile is awaited, but myositis panel has come negative. Her echo was done, which was reported normal. Right heart catheterization done twice, which was also negative. And her spirometry, which was done recently, is like this. I think this is from 2021. After that, I asked whether she would like to try. She told she cannot try anymore. So this is the only latest spirometry is around 2021. Spirometry was FEV1 of 40% with FVC of 41% and DLC of 30% with KC of 68%. I think that sums it up all, and we can go for CT images.
What was her saturation, Asmita, in 2021 on room air?
That is what she's saying, that since that time she was put on oxygen because of desaturation, and she remembers it was almost always 92 to 95. Yes.
Okay.
Asmita, I also saw the patient recently.
Uh-huh.
Before you saw, I mean,
Yeah.
they just came to me also. At that time, she was not on regular oxygen. She was taking it when there is hypoxemia. That's
No.
maybe another 3 months before that.
Yeah, sure.
Yeah.
Oh, good. Yeah, so she is now on continue. And second, she was traveling from Calicut to Kochi. I think that is also some 6 hours journey. I was surprised that she could travel. Yeah. Yes, sir.
Okay, so we have two scans. The first is of 22nd July 24, and then we have one 4 months later in Jan 25. So if we just look at this one here, when we start from the top, we see that there's a lot of exuberant honeycombing in the anterior upper lobes. There's also ground glass. Then some axially oriented reticular opacities. Again, we get this right middle lobe proximal ground glass and reticular opacities, some ground glass here. And then as we come to the bases, a lot of honeycombing and that typical peculiar exuberant honeycombing that we see with, scleroderma and those connective tissue diseases. And then 4 months later, her inspiratory effort is a little better, but there doesn't seem to be any significant change. So what we have is a fibrosing ILD with honeycombing, with many features highly suggestive of connective tissue disease ILD. But if there is no CTD, then I would also argue that maybe there is a whole genetic component to this, because then that would explain the bizarre appearance that we're seeing here. But just I can't tie in a 33-year-old with all this that we have. But basically, that's what is there.
So this particular CT scanner, sir, even when I saw, I felt it is a classical that four corner sign, and exuberant honeycombing and there were so many things which were going in favor of CTD ILD. Even the previous hospital, I believe it was diagnosed as CTD ILD only. And then they started her on some steroids and MMF. No, steroids they started in Ireland, they started her on MMF. And now currently she is on 10 milligram of prednisolone and MMF along with that. That is what her treatment. So there were a problem from Rajan sir was like whether we should do biopsy before sending her for transplant, one. And second was like what is her diagnosis, what whether we should do biopsy or whether we should do transplant also or not. And do we need to consider antifibrotic before transplant? That is what, right? Rajan sir, that were your questions.
Let me rephrase a little a
Yeah.
bit of what
Yes. Yeah.
Asmita has seen, because I've been talking to this girl before she came from Ireland to Mumbai, to Kerala. And I think her issue was that in Ireland, people are driving. Her first issue was people are driving very safely in Ireland. And so that's why she's not getting lungs in Ireland. And therefore, she thinks she'll have a better chance of getting lungs in India. And then I said, what's your off room air saturation? And as Asmita, who has seen her in clinic, it's about 92, 93% on room air, but her quality of life has taken a dip, which is not acceptable to her, in that walking up a flight of stairs or doing things are not easy for her. Now, I couldn't understand how this patient is waiting 5 years and she was using 2 oxygen concentrators. That was what the Irish report said. You remember, Asmita? 2 oxygen concentrators in the house.
They are very much motivated about everything. They were asking me that, do you have 20-liter one oxygen concentrator? Then I told I have never heard. They found out there is one.
Why
Yeah.
would you use 20 liters when you're
Yeah.
92, 93% on room air,
She's
Asmita? It didn't make
already
sense.
using 10-liter one, and she was
Right.
asking me what is my opinion about 20
Correct.
liter per minute.
Yeah. The second, so the thing is, I'm not clear what we don't have a scan of 2021, Asmita, or
2021 I could not get, sir.
So
That was
Ireland
only
is not releasing that. Okay. So because that's also important to understand. Right heart cath is normal. And I don't know if this is exuberant honeycombing. Is this exuberant honeycombing, Bhavin? You're muted, Bhavin. You're muted, Bhavin.
Yeah. Yeah,
Sorry.
no, there is no I mean, there is exuberant honeycombing. This is exuberant honeycombing.
This you would call exuberant honeycombing?
Yeah. You can see that in the
Can you
anterior
show the
segments.
sagittal or the coronal? Yeah, sections.
Let me just, 1 second. So this part here, the anterior segments of the upper lobes, this is all exuberant. And if I can do a sag, there you see all of that here. That's not normal. That's a little too much, and that's like your anterior upper lobe sign and things like that. But,
Sure.
But if you wanted to even look at it from that perspective, there are these sharp edges here. I mean, I don't think so. The straight edge sign is just a subset of this whole point where you get sharp edges between normal and abnormal. So that kind of, I don't know. Do you think everything sounds a little fishy here?
Yes. Which is why I wanted to bring. I told Asmita, let's get this to MDD. And I am sort of just not convinced she needs an urgent transplant. She's flown from Ireland. And yes, please go ahead.
Sujit, the patient's history says that everything has started after COVID vaccination. Okay.
No. It started 2019. 2019, sir. 2019, COVID was not there. Yeah.
Yes.
No, the need HRCT
need of oxygen.
HRCT pictures.
No, but before that, she went to a hospital where her CT scan. Actually, we can get that was in 2019 January or February, and that was diagnosed as CTD ILD with fibrosis. Yeah.
Are there nodules, septal nodules? Okay. On the HRCT. So
no, not really. I think, what's happening is that if you look at the Jan scan, you'll realize it's not there. I understand the other scan. Some couple of sections look like there could be nodules, but there aren't actually. It's just the way. See, it's an expiratory scan because she has poor inspiratory effort as well. Let me just show that again. 1 second. So if you see this, the trachea has always been like this. So I have a feeling some of the uh, what looks ghastly is simply because her inspiratory effort is not very good. And then the second scan is not actually an HRCT scan. They've just given us some soft tissue lung windows. So that's again why you think there's more confluent ground glass and things like that. But it's all basically just this. But Sujit, my thing is irrespective, this is extensive disease. I mean, you would
Yeah.
say that more than 50-60% of the lung is involved. So isn't that by itself significant enough?
But she's 5 years on a transplant wait list, Bhavin, and she's talking comfortably when you speak to her.
So
No, I would not agree with
but
you,
that's
sir,
an
because
interest.
yeah. No,
Yeah.
sir.
But
She was not comfortable. Maybe on monitor it
Sure.
looks like,
Sure, no,
but
you saw her. So
yeah. So
that's
when
I
I
defer
saw,
to
na,
you.
sir, even with oxygen, she was taking lots of effort to talk, and otherwise she's so young and so vivacious. Like we would somehow I might be biased, but I also would agree with her if she wants to go for transplant. To be very
I'd
but
honest.
defer to
it's in
Athol is closer to the Irish. Maybe he knows what they're
but
thinking.
Yeah.
it's just interesting. I couldn't that the way you put it. They drive safely in Ireland, therefore she couldn't get a lung, so she comes to India
No, not
because,
that
and it
only.
is true, India
Mhm.
is has the highest rate of road traffic accidents in the
Accidents.
world.
Yeah.
So
Yeah.
there is
Oh
no
my God.
question about that.
Actually,
So imagine.
there was another issue. She was telling she's actually short.
Smart. Yeah. Height
The
wise.
people in Ireland is
Big and
that's
yeah.
another reason. Yeah.
And
Yeah. That
further investigating her by bronchial lavage can guide us to decide about rituximab therapy in her before
she
considering.
received 2 doses of
Oh,
rituximab without any further benefit. She has actually Ireland people tried everything other than biopsy.
okay.
Yeah, Professor Wells.
Thinking about transplant, if we can somehow work out whether it is more likely in her case that something has burnt out, that would be hugely useful. With that in mind, I just want to go back to COVID and understanding she had a problem before COVID. She has a predilection for immune dysregulation. Her mother has rheumatoid. She has a history of hypothyroidism.
Yeah.
I think I would want to know whether following COVID, there was a sort of long COVID course. I'd like to know about fatigue and brain fog in the next year, because we do know these patients. Buried in there, I appreciate a minority, probably a small minority of COVID patients. But once we've got our head round that every post-COVID problem isn't lifelong fibrosis, we get this weird combination of patterns following COVID in small groups of patients with features that suggest immune dysregulation, which we're still struggling to classify in its various forms. So I would be wondering, and you can go back and tease out how much this got worse with COVID, whether there were long COVID symptoms, whether the COVID played a key role in inducing an immune dysregulation, and in that case, can we find evidence that this has burnt out and that she's likely to be stable from now on? Because if that is the case, I think her life expectancy might be better without lung transplantation. So it's just a matter, can you tease that out? Because I wouldn't dismiss the COVID in this case, unless you were to tell me that the disease was bad before COVID. But to me, it matters hugely whether the COVID signaled what was then a major step downwards. And if she's got a problem pre-COVID, then COVID might particularly bring out immune dysregulation in her case. So I wouldn't be making a diagnosis except to say that I think we get clear CT support, and Bhavan points this out, that a form of immune dysregulation is likely to be driving this. And I think we might have more than one trigger here.
If I can ask you, Athol, if we could see stability for another, just hypothetically, a few more years, then would you recommend, and I know we don't know what will happen in the next 3, 4 years, but she's remained almost status quo the last 4 years. Would you recommend doing a transplant after 4 years or now?
No, I think my worry is that the mortality post-transplant.
Yeah.
So if she's really been stable for 3 years, and we've reason to think that there was a more aggressive process that burnt out, and that's why I want to focus on what changed with COVID.
Sure.
And if we see there's stability for 3 years, and you can do your 5-year survivals post-transplant, my fear would be that her survival drops fairly sharply if she has a transplant.
Sure.
I mean,
you get my point, yeah.
And I agree with you, Sujit. Just an extra year by year makes you more confident. But I think 3 years of stability is enough to say, whoa, do you really want to go this route?
So what was happening was I was telling her to go to meet Asmita for a 6-hour drive, and she said, "How will I do it?" I said, "With a 93% SAT, you will do it." And then she said, "But the transplant team is constantly calling me to come and meet them." That's when I got a little worried. I said, "Let's just meet Asmita first, and then we'll take it from there."
Look, there's no harm in her meeting a transplant team
Sure,
so that
sure.
she is known to them. They
Sure.
do the tests, provided there's a mindset that they're not just going to go ahead willy-nilly,
Correct.
that she's ready to move. And then if she turns out to be progressive, you don't lose a lot of time with a new evaluation. The main thing is she doesn't get onto an automatic list and get stuck on transplant willy-nilly.
Sure.
And furthermore, I'd like to kind of I have noticed that dilated esophagus and in the CT scan closer to the
Yeah, I
hymen.
also, yeah.
I think we should manage the reflux fairly kind of intensely to prevent the progression. Furthermore, I mean, when you have such a dilated esophagus, transplant would be anyway. There's a high chance that patients can develop clad and all when there's a dilated esophagus. So I think transplant, I would agree with Prof. Wells. Transplant is not the option. I think we have to manage the disease, and we'll keep the patient in the list. But before the transplant, I think we should optimize the reflux if there's at all.
Absolutely. One of the things I've just posted the indications for lung transplant and ILD on the pan-ILD group. The important thing is progression to get onto a list. Until then, it's only referral. So it makes a lot of sense to keep her on the referral list, referral stage, but not move her to the list right now. And perhaps she's just very anxious. Dr. Asmita, have you thought of getting a psychiatrist to see her? Because, she's stable. She's got a 93% saturation. Is she just very anxious, and should she see a psychiatrist who will help her with that part of it?
I don't know. It will be difficult to convince her. She herself is a staff nurse. If I will tell her something like that, how she will take it, I don't know.
Shouldn't be an issue. You can tell her doctors also meet psychiatrists. That's not an issue.
Absolutely. No, and she has an illness which is very severe, and it'll be surprising if she doesn't have a psychological element
I know.
affecting
You're
things.
right, sir. But I don't know, sir. Maybe I had seen her cynosed on oxygen also. I don't think it was a psychological thing, which was because when we are seeing her like 92 saturation, but her peripheries and all are, and we can see clubbing and
No,
all full-fledged.
I think
I
what
don't know.
Murli is saying is whether the anxiety is compounding problems for her
Increase in the
more than
problems.
anything.
Yeah, sure.
And if she's cyanosed in your cold room, then maybe it's a Raynaud's phenomenon. It supports the connective tissue disorder.
Yeah, I know. She has it's better. She wanted very badly a decision from our side whether she should go for transplant or not. I think I will put those
And
questions.
further, I would maintain our rituximab actually. I mean, if there's no contraindication, I'll give once a year, maybe rituximab to maintain the disease. If that would be helpful, I think.
Yeah, that's
So
interesting.
no transplant as of now. You people, Athol sir wants me to find out whether COVID did the maximum damage, and in that case, this is burnt out disease, and we can wait and see for the stability of the disease. And other than that, anything which I have to or sir has to tell her. That's it, right?
Professor Wells, do you think it's the COVID that did the damage and stopped, or do you think COVID has caused an immune dysregulation which will then progress? Because we've seen that with other conditions.
Well, my suspicion is it's two factors, that she has a predilection anyway towards immune dysregulation, given that she had some disease before COVID and her mother had rheumatoid and she herself had hypothyroidism. And then you put in COVID on top of that. But I would then tease out with her whether the COVID resulted in a stepwise worsening and whether she had long COVID symptoms over the next 12 to 18 months. And I think you can make quite a formidable case. I was going to put up my hand and the rituximab suggestion was made because the issue is, irrespective of transplant, how you now manage this going forward. And I wasn't going to tell you, I was going to ask Sujit and Nazmita what they felt about that. As I haven't got a straight answer on it, I thought I might as well deflect the question.
What was your question, Athol? Sorry.
Managed medically from here, what are you going to do?
Yeah. I think Amila's idea about an annual rituximab dose is not a bad idea. But I can't think of anything beyond that. You did a myositis profile as well,
Negative.
Asmita?
Yeah.
My question really would be whether you go to, even if it's a low-dose immunomodulation approach, whether you think about, for example, without going for a very high dose, introducing mycophenolate or not. I think it's more difficult because you think it's been stable for 3 years, but her reserve is before that if using mycophenolate were to prevent a need for transplant, that would give you a big uptick in overall long-term survival. So I would.
She's on MMF, sir. She's on 10 milligram of prednisolone and MMF 500 twice daily.
I missed that. The case has been.
Athol, Ireland didn't give her an antifibrotic all these years because her DLCO was below 30%.
Do they have that restriction in Ireland, the DLCO?
Yeah.
Well, I think there's. Look, the real difficulty is stability for 3 years. Now, if you didn't have that, you would give an antibiotic for sure. You would probably go for a much higher dose of mycophenolate. Now you've got 3 years of stability. It is slightly guesswork, but I do think we don't know if this will progress or not.
Yeah.
We think it might not, but if it does, she'll need a transplant.
Yeah.
So I would be inclined to play the odds in terms of survival. Introduce an antifibrotic agent, which you can always withdraw in 2 to 3 years' time if it's completely stable. And I wouldn't go higher, I think, than what she's on with the mycophenolate and steroid. I guess my only question is whether you actually bring the steroid down a bit, use the rituximab, buying into the rheumatologist's views that far too much steroid's been used for far too long across a whole lot of diseases. So the rituximab might allow you to bring the steroid dose down. But I think I personally would want her on an antifibrotic with a view to reviewing in due course, if things are completely stable in 3 years' time, whether you bring her off rather than gambling and then finding she's moving to transplant and only using an antifibrotic drug at that stage. But this is guesswork, calculated guesswork. So I guess so much depends on that conversation you have with her.
And would you do
What
genetic?
if she progresses within 1 year, sir? 3 years is a long time, right?
No, I think what you're saying is that you're worried that she might progress. You might be able to prevent it, right? Now, if she does progress, she'll end up being transplanted. Maybe she has a 50% chance of being alive in 6 years following a transplant. But you think that actually, if you manage to stop progression, her survival will be far higher than that without a transplant. So how lucky do you feel at this point?
Sure.
And Athol, yeah, sorry.
Are you going to ask Sujit?
Yeah, I was just going to ask about telomere surfactant gene mutations and whether we should measure the
Yes.
length of her telomeres if possible.
Yes, because if she does have short telomeres, you're more worried about immunosuppression being too high. And I do think that's even though this would be bizarre, but I guess whenever disease is so weird, looking for genetic predilections is always a good idea.
Yeah. Is that it?
That's super. No, I think this is a very useful discussion on her. Thank you. Thank you, everyone, really.
Okay. We'll move to the third case.
Yeah, it's 6:12.
Yeah, I know. I'm so sorry. I'm so sorry.
Are we doing a third case? Otherwise,
Yeah.
can't
Third
we
case
do
we
it
have to
this
do,
way?
na, sir?
It's a quick one. It's a quick one.
Yeah, quick one.
Okay.
So this lady, Bhavin, you have the scans with you. This
I
lady,
do.
59-year-old, came from Udaipur. But she was in Mumbai before that, where she had pigeon exposures at a temple for 10 years, hypertensive. Mild chest pain and back pain were her symptoms when she came, occasional NSAID use for the last 4 years, no cough, non-progressive grade 1 MMRC dyspnea for the last 6 months, a largely sedentary lifestyle except for some housework in her village home near Udaipur. Bilateral inspiratory squeaks on examination.
Sujit, sorry, I don't have this. Huh?
You have
I
this.
pulled out NS.
Oh, no. This is NJ.
I don't
Do
have.
you think you can pull it out? See if you can. NJ. I think I sent you the scan on the mail. The report.
1 second.
It'll take you a few minutes to do it. That's fine.
It will take time because I seriously thought this was it's my bad.
I needed the PAT slides as well, and so I thought I'll do it next time when we can get the PAT slides.
Okay.
Oh yeah, this one. No. It'll take time. I'll have to download the entire scan and it'll take about 5 to 10 minutes. I'm so sorry.
We can do it next time. That's not a
Let's do
problem.
it next time. I thought this was NJ. Unless you want to just ask, since Athol and everyone's here, do you want to just run through the NS thing?
Yeah, you could. If you have the NS.
You remember the history? I have it downloaded. Like I said, I
have
thought that was what we were presenting. So
1 second, I have the history. Moment.
You can share the screen, sir.
okay, I'll do that. I think just run through the scan first and then, maybe have him come down.
Bhavin, as a radiologist in India, you're used to that. No history, only scans.
You bet.
So this girl, let me do the history because this girl is. I wanted to get the PAT slides for this girl, and because we don't have them, but there's a
Are you
mix.
showing you showing a presentation?
No. I'm just reading out her history. I have it.
Okay.
She's a 20-year-old married girl with no children. So very young married girl, and she presented with a left pleural effusion in November last year, started on empirical anti-TB treatment, developed drug-induced hepatitis, and then they put in an ICD for the 1 week before I saw her in early January. She lost a couple of kilos. She was also coughing. She had facial and pedal edema, and there was no joint pain, but there was a rash over the malar area for the last 3 months. Her echo was showing a moderate pericardial effusion, and the pleural fluid cytology was negative. Proteins were 3.8. There were 50 cells, all lymphocytes, and the ADA was 29. And she developed this drug-induced hepatitis, so bilateral hemorrhagic effusions, anapericardial effusions with anasarca, received empirical AKT for a month, developed hepatitis, stopped, ICD in situ when I saw her. And so we admitted her, got her chest scans done and a PET scan done. And Bhavin said, go for the left supraclavicular node. And before I tell you what that supraclavicular node showed, I think maybe Bhavin would like to run through the films.
Right. So what we have are two scans, 6th Jan and then the PET of 25th Jan. So if you look at the 6th Jan, let's just look at the mediastinal windows. You have a whole lot of what looks like lymphadenopathy. Looking necrotic, but they were not enhancing. You can see subcarinal, hilar, kind of infiltrating also along the bronchovascular bundles. There's some pericardial involvement as well. And this was the mediastinal presentation. And if you look at the lung windows, you've got septal thickening, which is your typical edema/infiltrative pattern. And as we go down, you see the peribronchovascular opacities. Then we see the septal thickening. There's a little bit of crazy paving with ground glass. And so this is what we have. Septal thickening, ground glass, crazy paving, telling us that we're dealing with an edema/infiltrative pattern. Now, how do you tie these up together? And I think that's where, to me, when I saw this, my colleague had seen it first. So by the time I was in the picture, the biopsy was already done. And when I looked at it, I thought we've seen TB sometimes behaving like an ILD. So I said, maybe that's what it is, very aggressive. The other thought is always lymphoma, but lymphoma rarely has these low density areas. And I completely missed the diagnosis. I mean, that is to be said. And eventually, after the histopath came, we did a PET CT, I think, and it just basically shows the same thing. We wanted to see burden of disease. The burden of disease is only the chest, and that's about it. There is a nutmeg appearance to the liver, and there's a congestive hepatopathy. And I think that's basically because of the vascular encasement that is there all across. There's hardly any uptake on the PET, and this is where we are.
Yeah, so I think this lady was really poor, this very poor family, and I have to thank Bhavin for doing a lot of stuff pro bono on her. And we got this ultrasound guided biopsy of a supraclavicular lymph node, and the pathologist called me up and said that, in fact, by then the chest physician from Nasik, where she lives, which is about a 4-hour drive from Mumbai, had said this is drug-resistant TB and had put her on second-line drugs and steroids. And then we did the biopsy, and she said there's lymphatic channel dilatation, and she said it looks like lymphangioma. So I had never actually diagnosed or treated a lymphangioma, which
No,
presents.
so now
Yeah.
I'll interject. So the moment I heard that term lymphangioma, I just hit my head like that, and I said, this is just diffuse pulmonary lymphangiomatosis. It's just so classic. It's infiltrative disease here. These are lymphangiomas in the neck and the chest, and it just fits perfectly. And so that's what it is. Now, we thought of doing a lymphangiogram just to confirm the abnormal lymphatic distribution, but she can't lie down. She's very breathless, so we couldn't inject an inguinal node to do that, but it's not really required. This is reasonably characteristic enough, and you just need one histopath from anywhere, either the lungs or the soft tissue, to tell us that, and it all fits in. And that's where we are.
But I've never treated this, and I really wanted to bring this with the slides. And so I'd love to get input from anyone who has treated it.
We should discuss
And
this.
we'll get the histopath next time. Ritu's also not here. I'd love for her to see those slides. We did start her on sirolimus a week ago. And I think her swelling on her face is less, but she still cannot lie down. Any thoughts from anyone? Prahlad, Athol?
Somebody has to say something, I guess.
Yeah, you have to say.
I strongly agree with your initial therapy. And if she's improving already, I would be inclined not to do anything else for a little while.
The surprising part, Athol, is that I called in my nephrologist to understand how to monitor sirolimus, and 80% of them have never used sirolimus. They either use everolimus or tacrolimus nowadays. So I really want to know if someone has experience with this.
We have to use sirolimus for lamb, and okay, and we have to gradually increase the dose from 100.
What's your target level, Prahlad? What target would you look at for levels? Because what I was reading was 12 to 20 nanogram per ml.
Correct, I think yes.
Okay.
Generally, 1 milligram to 2 milligram twice a day is sufficient.
Yeah, so she's on 1 mg twice a day. 3 days later, we did a test, but I think someone went and collected that blood after the morning dose instead of doing a trough level. So I'm going to repeat that now. That level was 9. But I'm really hoping if she recovers, this would be the first time I'm seeing this.
But sir, I would like to say something. Recently, we had because we are having here particularly my department has got pediatric pulmonologist, and he called one MDM, and I can recall almost similar CT scan of a 14-year-old boy whom he did E-bus, and granulomatous inflammation came and started on TB medicines because the manto was positive. But now, if I recollect, because we are planning to do a PET CT. I don't know. Maybe that now because you had shown me this, I
Yes.
can think of this.
Yeah.
That is
And
what I was.
that's the age group it presents. It's
Yeah.
actually a congenital problem that presents in the teens,
Yes.
up to 20.
Now I can recall that particular child. We all agreed to start empirical TB medicines like started in your case, and we have told that okay, after 3. I insisted we should do PET CT, which was not gone well with them, but I insisted that we should do PET, and maybe I will insist again, and I will tell him about this case. So, is it like that, sir? EBUS will not pick up, and you have to do TrueCut or something like EBUS will be FNSC.
No,
Yeah,
I think
FNAC may not pick up. Yeah, you need a core biopsy.
You need a core biopsy.
Okay, I think
And I'll
they
get
did
the
try.
slides. Let me get the slides and let's present it at an MDM, and we'll give time to Murli, Prahlad to figure out what we can do
So,
more
so
for this
this
girl.
sirolimus will work, sir. Those all lymph node, like such a big
Yeah,
lymph node will go.
They are not lymph nodes. They are lymphangiomas that look
Okay.
like lymph nodes. And the response is supposed to be miraculous. If you see the
Wow.
case reports so it can be sirolimus, tacrolimus. There are a couple of other drugs, and I think over a period of, they respond. That's the whole point. And so if we can do that, I think that works very well.
It will be very interesting to see. Wow.
Okay,
I have to. It was
Yeah,
a
you go.
perfect MDM case, Asmita, where
Yeah.
the pathologist just had to utter the word and Bhavin said yes.
Yeah.
That's all I needed.
Yeah.
Anyway, I had brain fog, I think, when I was looking at the case. All right, see you guys. I really
Thank
need
you.
to go.
Thank
Thank you
you,
so
sir.
much.
Thank you.
And
Thank you
thanks,
for
Asmita.
everything. Thank you for everything,
Take care.
sir.
Bye-bye.
Yeah.
Bye.
Yeah.
Thank you.
Bye.
Great fun. Bye.
Yeah.
Bye.
Bye.
Bye, everyone.
So I wanted Rajan sir, when
Are we
will we have the
offline?
next?
Are we offline now?
Manish, can we make it offline? Thank you so much, everybody. But we have to discuss the next date, and that is what we have to announce, sir. What time we should have? Matlab, which day?
So I'm fine if it's the 14th, but I'm flying at that time. So that's why I was wondering whether we
So
can
we'll
do it 21st
21st?
onward. Yeah.
Yeah,
And then
we should do
fortnightly
20.
after that. Yeah.
So then after that we will do 21st ka 2 weeks later, right?
Yes.
Okay.
That's right.
So then
So
we will have 21st MDM.
Yes,
first and
Murli?
third Friday of every month?
No, first, no, it's not about first and second, sir. 21st ke baad, we will have 2 weeks, one more week gap. Yeah, one more week gap. So second week, every second week we will be doing. So if we are doing on 21st of February, after that it will be on 7th.
7.
Yeah, 7th March.
At all, it is so difficult to get records out of Ireland. I can get them more easily from Brompton than from Ireland. Why is that?
I don't know. I really don't know. But I've had some of the same difficulties. Just had to keep battering away, and maybe you recruit her to put some pressure on, actually.
Oh, she's done that. She's done that. They said they want it from her and they can't. We wanted the older scans on her also, just to see disease progression. And not giving her an antifibrotic, I mean, was also, I mean, you're listing her for transplant, young girl, not on an antifibrotic. Somehow things didn't add up.
Yeah.
Yes, I agree. I agree. And I think you were very wise to call a halt to that as a rapid fire action.
One more thing which the family was saying was they were actually little bit okay or well to do, but because of her illness, they are all deprived of whatever they have got. And what she's planning to do is after transplant, she's planning to fly back to Ireland because there her treatment is free. Whether survival will be different. Like you told that only 50% survival. In India, I agree, but whether Ireland survival will be more, sir, if she's going back to Ireland.
I suspect it would, and if she goes to Jim Egan, I'm sure it would, but I still think you might be looking at more like a 65%. This is guesswork, 5 years survival. And if she really is going to be stable from here, that mortality will be a lot higher with than without transplant. Maybe she's so compromised, she argues she'd rather take the risk in order to get a good quality of life, which is why I suppose going back and having that candid discussion might be crucial. And especially with what she says about flying back to Ireland. Giving her an active life. I mean, these are difficult decisions, but the main thing is that you didn't go to a knee-jerk straight transplant approach, and I'm worried about it as well.
Just as a little aside, we met somebody last week, a pulmonologist from Dublin, who says that their number of transplants has come down hugely. They used to do a lot of CF earlier, and that's come down with the CAFTARs. And for some reason, they hesitate to do transplants in pulmonary hypertension. So the number of transplants Ireland is doing has come down hugely. So I don't know if that will tell on, experience with follow-up. So that's something to keep in mind also.
Yeah. Even biopsies also, na, sir? The more we know, the less we do. That's all.
I guess, Murli, it's also that our, 2-3 things come to life. CF, I can understand. PH, I can understand the number of drugs we have. IPF, they're much older in the UK. What's driving our programs is just fibrotic HP, Murli. And they are young patients, that's what's been driving our programs. I
And
feel.
the rest, it's a lot of COPD, I guess.
Yes.
The pH as primary pH, I can understand, but I'm not sure I can understand pH stopping you going to transplant in lung disease unless you've really got a failing right ventricle.
Yeah.
The allocation scores in many countries actually give priority to transplant if you've got pH short of a failed right ventricle.
No, we were discussing group 1 pH. So.
Yeah, right. That I do understand. But in principle, with CF and PH transplanted less often, the proportion having transplant for ILD should be rising.
Absolutely, yeah.
Okay, Murli sir, you missed this thing, so I will send you PPT separately for your inputs.
Thank you, Asmita, for the whole year's effort, and may you have the energy to drive this for many more years.
I think we have got one more person, sir. We have to appreciate Prakhar also because he has already booked some 2 cases for the next. So at least till Prakhar kind of people is there, we will able to continue it because we need some people other than you and me to present. Otherwise, it will look like we both only keep on doing it. So
There are
that's
many more people now, I think. Absolutely.
Yes.
So,
I think you should.
Yes.
You should drive your experience to publication. I wonder about adding another 3 to 6 months, so you've got just a few more subgroup numbers.
Yes.
And to me, the cardinal thing is grouping all the diseases together and making a statement about change in diagnosis and concordance across all the diseases as your opening statement. And kappa values for before and after, that sort
So
of
you
thing.
want me to do only change of percentage of diagnosis change, right? From like 100 patient, then this many people had change in diagnosis, this many didn't have, kind of, right? Just
Yes,
simple.
Simple, but kappa values for diagnosis
Kappa values, okay.
before and after. So was the diagnosis the same? Was it different? And then you break down subgroups.
Sure, okay.
You interpret carefully because the OP series was so small in number. And,
I know. Okay.
You know, there's a lot of OP you wouldn't bring to a multidisciplinary discussion like this because it's obvious. So probably you bring really difficult OP and then you're not surprised if the diagnosis
So we can justify that by saying it in discussion, right, sir? Yeah.
That's
okay.
right. And I'd be inclined to amalgamate OP and SIP and NSIP because we're talking about subacute versus chronic NSIP in a way, and group those two together and then subgroup them perhaps. We can
But
talk
our numbers were matching with international MDM, sir. This CTD-ILD is the maximum concordance and followed by IPF. These two diagnoses maximum concordance, but HP surprisingly didn't have. I don't know why. That is what it says. So that's what our numbers are.
I think one of the pluses is you're reporting a new group and you're saying from day one, this is the impact of multidisciplinary diagnosis in a new group in a large patient cohort.
Okay.
You're reporting it as being across hospitals. So you're actually also reporting a form of telemedicine multidisciplinary meeting as compared to the usual single center multidisciplinary publications. You're coming from a country, obviously, where TB is likely to be a confounder. And so endemic TB and its impact on multidisciplinary diagnosis is another item of interest. I mean, you can catalog the various things this is adding, and you end up with quite an attractive package, I would say. But getting your numbers a bit higher will make it more attractive.
But we should not wait for one more year, right?
How many cases was it in the end? It was touching 100, 90 or
90, well, I have not added the last meeting, 95, and this 3 will be 98.
So
you might reach 100.
Go for 150. Go for 150. You've
so
got
that means, 2-3 more months. Yeah.
That much more power for some of your subgroups.
Sure.
You got my suggestion, Asmita, on the chat?
I think Prakhar has said thank you, and
I was just thinking you could get the best of Pan-India ILD MDD to a build session.
Best of, oh wow, we can.
Think about it.
We can actually. I have got all the PowerPoint. We have got all the PowerPoint presentations saved in my desktop.
Think about it, and who had presented it, and some which had really great discussion.
But who will decide the best? I think Professor Welsh.
Athol, no one else.
Sure. So, but we can screen it and send it to him and let him decide. Yeah, that will be best. So anyway, we were planning to do multiple MDM. So maybe all out of those, we can bring the best of all the cases like CTD, ILD, best of this. So
we can sit on that and discuss it.
Okay. Okay, then thank you so much. It was good.
Rare lymphangioma.
Oh, wow. I learned a lot.